Throughout my professional journey, I have always prioritized the health and well-being of the patient. So I'd like to share with you experiences that demonstrate the benefits of visualized endometrial sampling over blind curettage or biopsy. In this example, we'll take a look at a case that illustrates the benefits of visualized sampling to decrease the risk of complications, and most importantly, the complication of uterine perforation. This patient was a 67-year-old who underwent sampling for thickened endometrial lining. It was incidentally found, but it was 8 millimeters. And in this case, I was actually a resident and doing this case with an experienced OBGYN who had 30 years of practice. She wanted to show me how the procedure was done, so when we started, we did a hysteroscopy. She placed the scope in the uterus and did confirm that there was a large endometrial polyp, which she then decided to resect using a blind curettage. So she removes the hysteroscope and curettes using the sharp curettage and polyp forceps. The procedure seems to go uncomplicated. The EBL is very minimal. The fluid deficit is 200, and the patient's discharged home the same day. The next day, I happened to be on call on the GYN service, and I see the name of that patient come up on the ED board. So naturally, being the concerned intern I am, I look at the patient and see that she's in there for an inability to void since the procedure. She also has a fever and malaise, as well as significant pain. I open her chart and look at her labs. Her creatinine is elevated at 3.8, her white count is 20, and the notes from the ED nurse say that her Foley has been placed and has grossly bloody urine. Unfortunately, her pathology report also confirms my sickening suspicions that there's an endometrial polyp, but also smooth muscle and urothelial tissue. And so this patient with a high suspicion for a bladder injury at the time of her polypectomy underwent a cystoscopy and laparoscopy. And you can see here in the initial cystoscopy footage, there's a very large 6 centimeter defect in the dome of the bladder. So very clearly was the cause of her urinary retention, elevated white count, and fever. This was a sharp injury made from the polyp forceps going through the uterus. And you can see in this video here, we're placing a stent through that defect. And the laparoscopy confirms that that defect is in the dome of the bladder, and there's a very large corresponding perforation in the uterine fundus, where the polyp forceps went through the fundus of the uterus and into the dome of the bladder. This was an unfortunate complication with significant morbidity for the patient, and in large part was due to the fact that the procedure was done blind. This is a great example of why we need to collect tissue under direct and continuous visualization, because if we had been using the hysteroscope to remove that polyp, we would not have been able to go through the fundus of the uterus, certainly not without knowing it, and certainly not at all because we're visualizing the entire cavity throughout the entire procedure. So this case, which happened very early in my professional career, really cemented the safety of doing a hysteroscopy in order to collect tissue under direct and continuous visualization to avoid the complications of uterine perforation.